The broadcast is now starting. All attendees are in listen-only mode.
Hi, good afternoon, everyone. It's David Kanashko here. We'll be starting the webinar in about 5 or 6 minutes. I just want to make sure that you can hear my voice because occasionally I have microphone difficulty. So hopefully those of you who are logged in and listening in right now, if you can just type in that you can hear me okay, I'd very much appreciate it. Thanks very much, and we'll start our broadcast soon. Okay, I'm back. This is David Kanashko, Director of Education and Training here at Meditech Rehab and Bioflex Laser Manufacturer. Today's webinar is on laser therapy effects on spinal disc herniation, a type of condition that we see relatively frequently, and in clinical practice, obviously you're going to come across it. So I want to have a discussion about a bit about the pathophysiology of this condition, as well as some case studies and understand the effects of low-level laser therapy or photobiomodulation on herniated discs. Just before we get started, if you have any questions as we go along, please type them in. I probably won't get to them until the end of the actual session, so I will try and leave some time for questions at that point. However, if you have any technical difficulties listening to me or visually seeing what's going on, let me know and I'll see if I can help you out along the way. Okay, so let's go over some of the anatomy. Again, this is a review for everyone, but sometimes it's nice to have a review to just take a look to see what we're dealing with again. Recall that the disc itself consists of an inner nucleus pulposus, outer layers of an annulus fibrosus, both inner and outer zones as shown in the diagram, and of course it's attached to the vertebral body at the end plates throughout the cervical, thoracic, and lumbar spine. The intervertebral disc itself is a fibrocartilaginous joint. It makes up about a quarter of the length of the entire spinal column, and I'm sure you're aware it starts at C2 and ends at S1. It allows for compression, tension, and rotational motion, so it's really important aspect for movement of the spine. And what's really important to understand is that it's avascular, so it's actually the largest avascular structure in the human body. The outer annulus fibrosus, again, the outer portion of the disc, is made up of concentric lamellae consisting of collagen fibers. They're arranged obliquely at roughly 30 degrees. This adds for increased strength and tensile strength to that disc. The inner nucleus pulposus is gelatinous in structure, has a high water content, and it's important because it resists axial forces like compression. The blood supply, as I mentioned, it is an avascular structure. It receives no direct blood supply, but it does so indirectly through the vertebral body end plates. So there's a network of vessels located centrally in the end plate, and this allows for nutrients to diffuse into the nucleus pulposus and annulus fibrosus. So again, no direct blood supply into that tissue, which makes it very difficult for the human body to heal if it's injured or compressed or torn. So the types of and the terminology used to describe injuries to the disc are quite varied. It's accepted that when we talk about a disc bulge, that this is a bulging into usually the anterior epidural space. And typically there's no focal area of outpouching. So in other words, a disc bulge is quite commonly found on MRIs and CT scans, and not necessarily symptomatic, although a disc bulge can in fact cause localized back pain in and on its own, but doesn't usually cause radicular radiating pain. Whereas a disc herniation, there's different sort of categories of that. This is where you actually have a diffuse eccentric outpouching of the actual intervertebral disc, ranging from protrusion, which is basically a contained bulging that occurs, or herniation, through the layers of the disc or the annulus fibrosus as shown. Whereas an extrusion is non-contained herniation, typically will go right through all of the layers of the concentric lamellae of the annulus fibrosus, all the way to the more serious sequestration type of herniation, where the nucleus is actually extruded right out through the annulus fibrosus and into the spinal canal or the nerve foramina, which can cause a lot more serious inflammation and damage. So there you have it. Those are the terminologies used to describe the different stages or the different types of disc bulges and or herniations. Again, to correlate that to pain, as I mentioned, a bulge or even a mild protrusion may just cause back pain, or if the protrusion is starting to compress a nerve root, then of course you can start to get radiating leg pain or in the neck, arm pain. Once it is completely extruded or prolapsed or ruptured, then you can start to get a lot more serious leg pain. You can start to get other serious signs and symptoms that oftentimes require surgery. So the pathophysiology of these types of conditions is such that the annulus becomes weakened or torn. This is usually due to repetitive trauma. This causes that nucleus pulposus to herniate through it, as I've just mentioned. Risk factors for disc herniations include prolonged standing type of occupations, age-related changes, poor body mechanics, being overweight, trauma, that type of thing. The majority of spinal disc herniations occur in the lumbar region, with 95% approximately occurring at L4 to 5 and L5S1. The second most common site is in the cervical spine, and again, the mid to lower portion of the cervical spine, C5 to 6 and C6 to 7. The thoracic region is actually quite rare as far as disc herniations go, with less than 5% of herniations that are found in the spine occur in the thoracic region. Oftentimes that occurs with trauma. One of the more famous cases of thoracic disc herniation was back in the day Wayne Gretzky, that was out of commission with thoracic disc herniations. So herniations usually occur posterolaterally, where the annulus fibrosus is relatively thin and therefore is less reinforced by the posterior and anterior longitudinal ligaments. Signs and symptoms. Again, I'm going over this pretty quickly because I'm sure we're all familiar with this. Just a nice refresher. Of course, there's pain. Depending on the extent of the herniation, there may be paresthesia, numbness and tingling, decreased sensation if the sensory root is affected. The pain usually increases with increased intrathoracic pressure, like a Valsalva maneuver. Obviously, if it's affecting a nerve root, there'll be dermatomal distribution. There may also be decreased motor strength and or absence diminished DTRs if the motor roots are affected. Typically, you'll see muscle spasm and decreased range of motion because of that. Prognosis is really an important thing to understand. Of course, you need to know the extent of the herniation. So, sometimes a patient has severe pain, and that might not necessarily be correlated to the extent of the herniation. In other words, herniation may be mild, yet the pain is really severe, and herniation may be quite severe, and the pain may not be as severe. So in other words, you can't always correlate with the patient's symptoms as far as the level of pain and the extent of the herniation. However, typically there's substantial improvement usually occurs within the first 4 to 6 months after the initial onset of symptoms. Time to complete recovery ranges anywhere from 24 to 36 months in the majority of patients. And most patients do reach a maximal medical recovery within 1 to 2 years. I do have some references for these, so if you're interested in that, I can send that to you. And the stats that I researched was that roughly 15 to 20% of acute lumbar disc herniations go on to require surgical intervention. And usually that's after that first 4 to 6 months where they're not recovering the way they should, or of course if there's a medical emergency like a cauda equina or other emergency where the patient is experiencing major red flag neurological signs and symptoms. So that brings us to what can laser therapy or photobiomodulation do for disc herniations? Well, one thing it can do is help improve blood supply. Now remember that we can't directly improve direct blood supply to a disc. However, we can improve it to the damaged tissues and structures around the disc herniation, so that's very important. With respect to repair, this is really critical because we're trying to repair the collagen fibers that make up the annulus fibrosus. So by irradiating the disc itself directly, then you can increase the production of type 3 collagen and eventually maturation into type 1 collagen. So overall, this will accelerate the healing process of a torn or ruptured annulus fibrosis. Of course, there may be muscle tissue involvement as well. We know that photobiomodulation increases the number of stem cells or myosatellite cells that helps to repair damaged muscle tissue. So this is a really important aspect of helping with the secondary muscle involvement. Of course, inflammation and swelling is an important feature of the disc herniations. And I'm going to talk a bit more about the systemic effects on inflammation and how that might help disc herniations. Nerve regeneration, if there's compression directly on a nerve, then we know that photobiomodulation helps with the repair of neurons, especially remyelination or repair myelination with respect to Schwann cell activation or repair process. And of course, cartilage production, if cartilage is damaged in and around the disc, like the end plates, that may be helpful as well. And bone formation, if there's any damage to the bone and secondary to the herniation. So in a nutshell, photobiomodulation will help with all these different aspects of the healing of a disc herniation. Indirectly, that is systemic effects. So when we're treating a disc herniation, we're treating both directly with a laser probe, and we're treating all the blood and surrounding blood around the affected area. So what we're trying to do there is have an effect on the major inflammatory mediators like prostaglandins. Photobiomodulation inhibits PG. It also decreases inflammatory cytokines. That is, these are chemicals secreted by white blood cells that initiate and prolong inflammation. So light therapy or photobiomodulation is known to decrease these inflammatory cytokines, decreasing inflammation and helping with pain. And it also increases anti-inflammatory cytokines, that is, white blood cells that release these chemicals speed up the inflammatory process and help to resolve it. Another feature of systemic treatment or the blood treatment of light therapy has to do with the release of nitric oxide from its binding of hemoglobin. This leads to vasodilation in the direct area in and around the disc. So vasodilation will help with the blood supply to and from the discal area to facilitate and accelerate the healing process. And it also increases white blood cell numbers, which would of course help with this whole inflammatory process. Photobiomodulation is also known to release cortisol. That's a natural anti-inflammatory agent. It increases macrophage activity to help get rid of the debris and the damage of a disc herniation. And it can also help with pain. It's been noted to help with endorphin and enkephalin release as well. All right, so let's get on to two case studies, one in the lumbar spine, one in the cervical spine. I'm going to talk a bit about our approach and how we would help these patients. With respect to both lumbar and cervical disc herniation, we obviously want to identify and treat the source of the pain, not just the cause of the pain. Make sure there's a thorough physical examination, and to do any diagnostic tests when required. So again, you're trying to treat the disc area. You're not just trying to, block the pain temporarily. So after initiation of laser therapy, you want to avoid any long-term complications. So the sooner you can do laser therapy treatment, the better prognosis for your patient. So remember, healing first, get things going before you start to engage into any exercises, especially ones that may potentially aggravate the condition. So we want to start immediately, and usually we start treating 3 to 4 days consecutively. Then we go to 3 times a week. For a substantial period of time until things are under control and improving, we go to 2 times a week until, again, there's 70, 80%, 90% improved, and then maybe to a maintenance type of thing once a week for another few weeks or as long as it makes sense. Okay, so that's typically how we approach treatment. The first case is a 39-year-old land developer. He presented with acute low back pain and leg pain. He'd had similar episodes in the past. However, this particular one was the most severe of these episodes. He has had MRIs in the past. It had showed some bulging discs around that L4, L5, L5S1 area. The patient themselves, he at that time required a cane when he came in for his initial assessment. He had difficulty lying on the side, although that was the most comfortable position for him. He did have some scoliosis. It looked to be due to muscle spasm right from the TL junction all the way to S1, and there was considerable paralumbar muscle spasm in that same area. Very acute tenderness all the way again from T10 to L5. This is important because when we go to treat this patient, we're not going to just treat the lumbar spine. We're going to also have to treat the lower thoracic region because of the tenderness in that region. Again, some other findings: straight leg raise and decreased light touch sensation on the right L5 dermatomal region. The patient did have a MRI a few visits after he started treatment, and it showed the following. It showed some degenerative changes. It also showed a central disc herniation, L4, and then at L4-5 there was a right-sided disc herniation with compression of the dural sac, so we know that it was a significant herniation at that point that was affecting the right L5 nerve root. There was also some mild central disc bulging at L5S1, but however, there was no stenosis or impingement of the spinal cord at that level. So really, again, our examination and the diagnostic imaging indicated that the main area of concern is that lower lumbar region, especially on the right-hand side. So how we approached treatment was a little bit different than a standard treatment. What we did was we added an extra red dual array to affect the TL junction. That's what this extra bar is through here. We started off continuous wave, so we did 5 minutes of red at the TL junction, then 6 minutes just below that. We increased it to 8 minutes, so a fair increase in red at the L5S1 because that's where most of the area of concern is. We increased the time obliquely overlying the L5S1 nerve root, and then 5 minutes on the left side, again not as effective. When we went to do the infrared dual array, you can see that we added extra placements vertical overlying the TL junction and the L5S1 area, again because of the extent of the spasming and the area of damage. We started off with 50 hertz and 70% duty cycle, and we used both probes, our infrared 200 milliwatt probe, continuous wave. However, we did set it at 40%. We typically do that on the first few sessions and see how they respond. And we also use the red probe. Overall, there's certainly enough evidence now in the research to suggest that using both red and infrared is superior than just using infrared. And we use a total of 10 minutes for each of these probes, a substantial amount of time to affect and get enough light into the deep regions of the lower back. By treatments 3 to 4, in red, you can see what we did there was we increased the duty cycle to 90% for the infrared, and we increased the LDI 200 probe to 100%. Okay, so those are the two changes or increases we made as the patient was tolerating well the first 2 sessions. By treatments 5 to 6, we started to modulate the red, 100 hertz and 90% duty cycle. Again, modulation seems to have a better effect as a patient has had several treatments and maybe is plateauing a little bit. You can see we left the infrared at 50 to 90. By treatment 7 to 14, we increased the frequency of the infrared. And again, if you're not quite sure why we increased frequency, it has to do with how the light is stimulating the mitochondria, and it's a topic I've talked about before. That would be in our support page for previous webinars. So again, we're increasing here the frequency of the infrared, keeping the red at the same, and the parameters for the LDI 200 and 100 probe about the same. By treatments 14 to 27, we have substantially increased the frequency of the red, keeping the duty cycle of the red and infrared, and the percent power of the probes the same. So you can see what we're doing here is increasing the frequency as opposed to the dosaging. Okay, as our patient is plateauing, and we need to try and simulate the tissues in a way that doesn't alter the dosaging. And finally, once we got the patient on a maintenance program coming once a week for the last 8 sessions, we went back to 190 for the red and 50-90 for the infrared. So for the maintenance treatment, we did not keep it at the high levels found in the previous. We kind of went back to the mid-level treatment that we found to be effective to initiate stimulation but not overstimulating it. Okay, so that's an important point as well. The clinical outcome, again, it took about 27 treatments, which again, when you're dealing with a moderately severe disc herniation, that's to be expected. The patient was able to resume his normal activities of daily living, back to work and so forth, and it was about 35 treatments in total, including the once-a-week maintenance program before he was discharged. So that would be a kind of a typical what to expect for that kind of scenario. Some treatment tips is remember the depth of the target tissue is quite deep in the lumbar region, so you want to make sure you hold the infrared probe for long enough. You might want to start with 10 seconds or so and work your way up to 15 or so seconds in one spot if you require that. You want to focus the laser therapy on the target tissue, so knowing where the disc herniation is, make sure that you angulate and point the laser probe, depress the tissue to allow that light to get as close as possible to that herniation and the affected nerve roots. And don't be afraid to use the probe, the infrared and the red probe overlying the sciatic nerve and the exiting nerve roots. This will also help with the effects directly on the compressed nerve. Okay, so now a cervical disc herniation case study in the last 8 minutes or so that we have. This patient was a 36-year-old law student, had a 1-year history of pain in the neck that was causing radiation to both upper extremities, however, is much more pronounced on the right side. The onset related to the injury was related to an injury at the gym about a year prior to coming in. She had 2 months of physio, not a lot of improvement, was using analgesics as required, and did see a neurosurgeon, and that neurosurgeon had recommended a C5, C6 discectomy and spinal fusion. The patient was right-handed, and you can see the grip strength on the right-hand side was reduced. Range of motion was also decreased, and there was significant tenderness over C4 to T1, with considerable paracervical spasming on the right-hand side. An MRI of the cervical spine revealed a focal right foraminal disc protrusion at C5, C6 that was compromising or compressing the exiting nerve root. So that was the diagnosis, obviously C5, C6 right nerve root compression. And again, how we approach treatment in the cervical spine is a little bit different than the lumbar spine. Standard placements are vertical right from the suboccipital region down to roughly C4, C5, C6, and then another placement to overlap that lower cervical spine and upper thoracic region, and then obliquely on both left and right-hand side. We usually start with continuous wave with the duo red, 5 minutes of the red, followed by 6 minutes for those placements for infrared. We started this patient at about 50-50 frequency and duty cycle. The red probe we used at 50%. We decreased that from the total power of 100%, and same thing for the LDI 200 at 40% for about 9 minutes in total for treatment time for the probe. By treatments 4 to 7, we increased the duty cycle of the infrared to 70%, and we increased the power of the red probe to 100% for 9 minutes, and the LDI 200 to 50%. Again, what we're trying to do here is slowly increase the dosaging as a patient is plateauing. By treatments 8 to 15, we start to modulate the red at 180, start to increase the infrared dosaging a little bit more to 80% duty cycle, and 100% of the LDI 200 laser probe as tolerated. By treatment 16 to 22, the patient now was increased duty cycle for the red and infrared to 90%, keeping the laser probes approximately or the same at 100% for red and infrared. Okay, so in total, the patient had 22 treatments where the patient had significant improvement of her symptoms, roughly 90%. The range of the motion of the cervical spine had been returned to normal. The tenderness was marginal or maximally reduced, and the neurological exam was basically within normal range at that point. Wow, I actually speeded through that because I didn't think I was going to get time. But that gives us time for some questions, okay? So let me just take a look at our questions here. Give me a second. While you're looking at the screen, don't forget about our next webinar before the new year, and that one will be on patient education and laser therapy. Well, it doesn't look like I have a lot of questions here other than someone saying they can't hear me. So hopefully that was resolved. I don't get any other complaints here as far as listening in. Again, thanks for attending, and we will see you next month. Take care.